All right, let's jump right in. Today, we're tackling a topic that is absolutely fundamental to understanding metabolic disease and, of course, cardiovascular risk, the disorders of plasma lipoproteins. When the body's fat transport system goes completely haywire, well, the consequences can be pretty serious. So, let's get into it.
So here's our game plan. We're going to start with the basics of how lipids get around the body in the first place. Then we'll dive into what happens when that system breaks down. After that, we'll classify the disorders, connect them to the real-world signs you'd see in a patient, and finally, we'll wrap up with how they're diagnosed and managed. It's a clear roadmap to really get a handle on a complex topic. So first up, why do we even need this whole special system for moving things like cholesterol and triglycerides? I mean, why can't they just travel freely? Well, it all boils down to a really simple chemistry problem. Think about it. Lipids are fats. They're oily. They're hydrophobic, which means they don't mix with water. And what's our blood made of? Mostly water. So they can't just float around on their own. The body's brilliant solution was to package them into these little particles called lipoproteins. They have this special protein and phospholipid coat that makes the whole package water-soluble. Problem solved.
I absolutely love this analogy because it's so perfect. These lipoproteins are literally the delivery trucks of our circulatory system. They're picking up fats from your gut or your liver and hauling them to every single cell in your body that needs them for energy, for building membranes, for making hormones, you name it.
And just like the roads have different kinds of trucks, we have different kinds of lipoproteins for different jobs. Chylomicrons, those are the massive 18-wheelers hauling the fat from the meal you just ate. VLDLs are the trucks shipping out fats that were manufactured in the liver. LDL is like the final mile delivery van, dropping off that crucial cholesterol right at the tissue's doorsteps. And HDL, well, that's the cleanup crew, the recycling truck, going around and collecting all the excess cholesterol to take it back to the liver. So that's how the system is supposed to work, a perfectly coordinated delivery network. But what happens when it breaks? That's when we get into the world of disease, and the causes really fall into two main buckets. On one hand, you have primary disorders. I think of these as factory defects. You've inherited a genetic problem with one of the essential parts of the system. Maybe a crucial enzyme doesn't work, or a receptor is faulty. On the other hand, you've got secondary disorders, which are more like a system overload. Here, other conditions like diabetes or obesity or even some medications are just throwing the whole transport network into total chaos. Now, the clinical term for all this chaos is hyperlipoproteinemia, or you might hear the broader term dyslipidemia. All it means is that you've got a massive traffic jam of these delivery trucks in your bloodstream. The levels of one or more of these lipoproteins are just way too high. Okay, so to make any sense of that traffic jam, clinicians needed a way to organize the chaos. And the system that's been used for decades is the Fredrickson classification. It's a really smart way to pinpoint exactly which type of delivery truck is causing the pileup. And honestly, it's a beautifully simple idea. By figuring out which specific lipoprotein is elevated, you can start to understand the underlying problem and even predict the clinical risks. It just takes this messy situation and organizes it into distinct, manageable types, which, from a clinical standpoint, is absolutely crucial. Now, what's really useful here is how we can group these disorders. So, let's start with the ones where triglycerides are the main villain. In type 1, the enzyme that's supposed to unload those big chylomicron trucks is broken. In types 4 and 5, you've either got an overproduction of VLDL trucks from the liver or a mix of issues. But here's the key point, the thing you have to remember. The shared and very serious clinical risk for these is acute pancreatitis. When triglyceride levels get that high, they can cause direct chemical injury and inflammation to the pancreas. It's a medical emergency. And this slide shows us the other side of the coin, the disorders where cholesterol is the star of the show. In types 2A and 2B, the problem is with the LDL receptor, the loading dock for the cholesterol delivery vans, so LDL just builds up in the blood. In type 3, the body has trouble clearing away the leftovers from VLDL trucks, called IDL. And what do they all have in common? What's the major risk here? Premature atherosclerosis. That's the hardening and narrowing of arteries that leads directly to heart attacks and strokes. So for anyone studying for exams, this is your money slide. This is the high-yield takeaway. You have to group these disorders in your mind. Think high triglycerides, and you should immediately think pancreatitis risk. That's your types I, 4, and 5. Then think high cholesterol,
and your mind should jump to premature atherosclerosis. That's your types 2 and 3. It's a simple mental framework that makes this whole topic way easier to remember. Okay, we've gone through the lab classifications, but now let's connect that theory to the real world. What do these disorders actually look like in a patient? How do these invisible problems inside the blood vessels actually show up on the outside? Well, one of the most classic physical signs is something called a xanthoma. Basically, when you have this massive overflow of lipids in the blood, they've got to go somewhere. So they start getting deposited in other tissues, especially the skin, and they form these really distinct fatty lumps. They're a direct, visible clue that there's a serious underlying lipoprotein disorder.
For instance, if you see these firm, bumpy deposits on tendons, especially the Achilles tendon, your alarm bells should be ringing for familial hypercholesterolemia. That's our type 2A. It's a classic, telltale sign of severe, long-standing high LDL cholesterol.
Now check this out. If you see yellowish streaks that fill the creases of a patient's palms, those are called palmar xanthomas. And that is a hallmark, almost a dead giveaway, for type 3 dysbeta-lipoproteinemia. It's a fantastic clinical clue that points you directly to a problem with those VLDL remnants we talked about. And finally, we have eruptive xanthomas. These look like a sudden rash of small yellowish bumps, almost like pimples, that can pop up over the buttocks and limbs. When you see these, you're looking at crisis-level triglycerides, and that points you straight towards those triglyceride-heavy disorders, type I or type V. Of course, it's not just about the skin. The major consequences are far more severe. As we've been saying, the cholesterol-heavy disorders, types 2 and 3, are a direct pipeline to developing coronary artery disease. On the flip side, the triglyceride-heavy disorders, types 1, 4, and 5, carry that huge risk of acute pancreatitis. And one other classic sign, especially for type 2A, is something called arcus cornea. It's a whitish ring of lipid that actually forms around the cornea of the eye. All right, so we've seen the signs, we have our suspicions. How do we actually confirm the diagnosis? And most importantly, what can we do to manage these dangerous conditions? The whole diagnostic process usually starts with a simple fasting lipid profile that measures your total cholesterol, HDL, and triglycerides. From there, we might move on to more specialized tests, like measuring specific apolipoproteins, or even genetic testing to confirm if it's an inherited familial form. And the classic test to figure out the exact Fredrickson type is lipoprotein electrophoresis, which actually separates all the different lipoproteins. Now, for management, the foundation is always lifestyle changes, diet and exercise. But let's be real, for these disorders, medications are almost always going to be necessary. And the key is to match the right drug to the right problem. Statins are the absolute rock stars for lowering LDL in type 2. Fibrates and omega-3s are fantastic for getting those triglycerides down in types 1, I, 4, and 5. And for the really severe genetic cases, we now have incredible new therapies like PCSK9 inhibitors. And this really is the most important message when it comes to management. There is no one-size-fits-all solution here. You have to tailor the treatment to the specific lipoprotein that's out of whack and to the patient's overall individual risk profile. It's exactly why getting the diagnosis and the classification right is so incredibly important. And that leaves us with a really fascinating question to think about. For decades, we've just been managing the consequences of these factory defects. But now, with the explosion of gene therapies and a much deeper understanding of the molecular machinery, are we getting close to an era where we can actually fix the underlying defect itself? It's an exciting thought for the future. Thanks so much for tuning in.